Good evening and welcome to all the participants and my panelists for today's evening that's really focused on fertility and cancer or general fertility. I'm joined here with Dr. Evelyn Mok-Lin, who I'm going to ask to introduce herself in just a sec. Molly Dunn, a genetic counselor in the IVF clinic. Elizabeth Lynn and Veronica Fern, who are my amazing nurse practitioners in the hereditary cancer program. Over to you, Dr. Mok-Lin. Can you say a few words? What do you do? What does your clinic look like? Who do you see?
Yeah, happy to be here. Thanks for having me. I'm Evelyn Mok-Lin. I'm a reproductive endocrinologist and infertility specialist here at UCSF. I'm also a professor in the Department of OBGYN and medical director of the Center for Reproductive Health. I see people who are either thinking of having a family or actively trying to conceive. So it really runs the spectrum of everyone from people who are interested or need fertility preservation because of a cancer diagnosis or lots of other medical and elective reasons. And through sort of the reproductive lifespan of then wanting to actively build a family and doing either inseminations or IVF. And I see a lot of the what we call oncofertility cancer patients. So a lot of it is breast cancer, but also lots of GYN cancers, lots of blood cancers. So I see a lot of folks of all age ranges in that setting as well.
Great, thank you, and great to have you. Molly.
Hi, I'm Molly Dunn. I'm a genetic counselor at Center for Reproductive Health. I've been here about 10 years, but been in the field since 2003 in different specialties of genetics. At this position, we're doing kind of coordinating cases for pre-implantation genetic testing for either chromosomes and or single gene disorders, for example, BRCA, or many other indications for single gene testing. So we coordinate that, as well as there's a donor program in the clinic where we have kind of coordinate match consults with recipients and screen donors, either known or anonymous, and have lots of other indications for genetic consults as well, for example, family history. So yeah, happy to be here tonight.
Great and welcome. Veronica, can you say a few words on what you do and
Hi, I'm Veronica Fern. I'm a nurse practitioner in the Hereditary Cancer Clinic. And with my colleague Beth Lynn, we follow patients with hereditary mutations who have 2 or more risks for cancer. And we follow them throughout their life as long as they want to be with us. And we provide education, risk reduction, and screening for patients.
Thank you. And Beth?
Veronica did a good job of explaining it. We do the same thing. I think of it as an honor to work over a lifespan with people. I've been in the clinic for almost 6 years, and I've seen some of our patients go from getting married to having kids, and we deal with the changes that go on during those times and how to plan imaging and risk reduction through all the phases of their life.
Thank you. And before I introduce myself and the clinic a little bit more, I also really want to give a shout out to Lou Rumenance-Renard, who has done all the organization for this webinar, and it's really appreciate you getting us on track and making this happen. And a shout out to Danielle Sipes, who is doing our flyer. So I'm Pamela Munster. I'm a BRCA carrier, and I started this clinic in part because I realized how challenging it is if you actually have to manage the risk for multiple cancer across multiple disciplines. You find yourself as a mutation carrier as being a daughter of someone with cancer and a mother of someone with a mutation at risk for cancer. And I think I felt like it was so difficult for me as a medical oncologist at UCSF to find my way around. This is going to be really hard for many of our patients. So what we really want to provide is a resource of where people get their screening done, where someone orders their screening, schedules their screening, and then also makes the appropriate referrals that someone who needs to find Dr. Mok-Lin actually gets to her. So today we have done a whole series of these webinars. Today we really focused on fertility and what it means if you carry a risk for cancer. You may have to take your ovaries out sooner than you want to. Pregnancy may impose a risk of things. So there's a lot of questions we have. But let's start with the basics. Molly, what does a genetic counselor in the reproductive environment do? It's like, what does your day-to-day life look like? It's like help our patients see what you do, what you offer, what you're interested in.
Yeah, basically once a patient is referred to our department for usually they already know that they're a BRCA carrier and have those results, and they are assigned an REI doctor, one of the many doctors that we have here, to a care team, and then we see them for a PGTM consult if they're interested in screening.
Molly, do you mind if
Yeah.
we pin you down on not using acronyms or abbreviations, because we are not that familiar with that?
Sorry.
So REI and RPMs is like it's even for someone like me not so clear.
Yeah, by PGT I mean pre-implantation genetic testing for single gene disorders. It's called PGTM. It used to be called PGD, or pre-implantation genetic diagnosis. And so we take a family history during that consult, and then we talk about how the PGTM process works, which means that we will be referring their case to an outside lab where they review the mutation. And then there's a few steps that are involved for these patients, where there's an intake with that outside lab, a financial consult, and then they usually will collect saliva kits for their technology that they need, which is called linkage analysis. So they usually need saliva kits from the patients and their partner, as well as sometimes family members. And then they create a test probe specifically to look for that mutation. So it's a specialized test probe they develop. And then at that point, the patient can plan an IVF cycle where they're retrieving eggs, creating embryos, and sending biopsies of those embryos out to that outside lab for testing. And on that test, they're looking at not only the chromosomes like Down syndrome, but also for their particular variant on the same test. And those results take anywhere from 2 to 4 weeks to get back. And myself and the other counselor in the clinic, Natalie, we're the ones that coordinate those cases, as well as call out those results and give the results to the care team. So if people are lucky enough to have embryos that are suitable for transfer, then the patient would then schedule with their care team a frozen embryo transfer cycle, or FET cycle, where they would thaw the embryo and then transfer the embryo back to the patient.
Thank you. And I think from listening to, we can understand that this is a very complex and very sophisticated approach. Dr. Mok-Lin, can I take you a little bit back to the basis? Like, what's fertility, and why do people see a fertility specialist? Like, I mean, doesn't everyone just get pregnant?
Yeah, I mean, it would be great if people who wanted to get pregnant could get pregnant, and people who didn't want to get pregnant wouldn't get pregnant at the appropriate times. There's definitely a lot of stars and steps that need to align in order for a healthy live birth to happen. I mean, it's actually quite miraculous that it happens so often in an uncomplicated way. as often as it does, because there's so many things that have to really line up. So sort of my bread and butter, what I do the most is infertility, people who have tried to get pregnant, which is defined as either trying on their own, if that's a possibility, for 12 months, if under the age of 35, or for 6 months, if over the age of 35, or if there's any, if there it isn't an option for them to try to conceive on their own. So single parenting by choice, people who are same-sex couples, or for whatever reason they can't try on their own, then by definition, they also have infertility and need fertility assistance. Specifically in the BRCA population, it's a lot of conversations about family planning in general, what their goals are, what their ideal timeline is, with sort of the background, sort of hovering in the background is people with BRCA do have a shorter reproductive lifespan they have to think about, because if the ovaries have to be removed between age 35 and 40 or 40 and 45, depending on their variant, then that certainly reduces your window of opportunity. So that's something to think about. And then as well as whether they want to screen for the BRCA or whatever mutation they might have, but whether they want to screen for that mutation, like Molly was saying, via IVF. And that's not necessarily aligned with everyone's goals. Not everyone wants to do that, but we always want to talk about what those options are. And then the other thing that I think is important that isn't as well known is that BRCA1 in particular is associated with diminished ovarian reserve, lower ovarian reserve. So people with BRCA1 tend to have earlier age of menopause. They tend to have a lower response to egg freezing and IVF. They have fewer eggs retrieved. On average, it's 8 to 10 years earlier age of menopause in BRCA1 carriers. So that on top of the sort of 35 to 40 guidelines of risk reducing bilateral oophorectomy, removing the ovaries, that sort of might potentially pose an additional consideration for family planning.
Thank you. So I think in taking you back a little bit, is like, Elizabeth, Beth, of Veronica and I talk a lot of the patients, and as you know, child rearing and conception is pushed back to later years. Is like, and I think many of us feel or felt that you can have a baby late 30s, but I think it becomes more challenging. Can you speak a little bit, is like when natural fertility becomes more challenging, and like you mentioned that trying for 12 months under 35 is fine, but probably not more than 6 months after 35. Can you talk a little bit about why this is? And before we get into like what happens to people with mutations, what happens to the general population?
Yeah. So what happens with people with ovaries as everyone gets older is there's two things that's happening with the ovaries. One is egg number, so ovarian reserve, ovarian quantity egg quantity is going down. And then the other major component is that the quality is going down. So I always tell everyone that nothing magical happens on someone's 35th birthday. It's not like a steep cliff on their 35th birthday, but right around the age of 35, both of those things start to, the rate at which they decline, both start to increase. And so the number is declining a little bit more rapidly, and then the quality is declining more rapidly. And so one question that I often get is, what does it mean by quality? And it means just being able to conceive and have a successful pregnancy, which also means not just getting pregnant, but not having miscarriages. Miscarriages are usually most often due to what we call aneuploidy, which is extra chromosomes, or missing chunks of genes even. And that happens significantly more commonly as we get older, and especially over 35. So as an example, on average, at age 35, about a third, and Molly can speak to this as well, but roughly about a third of the embryos that we biopsy for genetic testing at age 35, about a third are abnormal. So 2/3 normal, a third normal. By age 40, it's roughly flipped. So 2/3 abnormal, 1/3 normal. And then with every year above age 40, it's dramatically more, such that by 42, 43, it's really unlikely to be able to have a euploid or chromosomally normal embryo.
And chromosomal abnormalities can lead to defects in the child, or can lead to pregnancy loss, or both of it, right?
Primarily infertility. That's the main reason why people just don't conceive, is that it's not a normal embryo. It doesn't even implant. But also early miscarriages. So first trimester miscarriages.
Mm-hmm. And then Molly, do you have like a bit of a summary for our young patients? What are things that happen in families or occur in families are sort of like red flags why someone should seek genetic counseling or prenatal testing, other than having a genetic mutation in the BRCA? But what are other flags in the family that people should be aware of?
Sometimes people are found to have what's called a chromosome translocation, where 2 or more chromosomes could be translocated on each other, which makes a much higher chance for miscarriages or not being able to get pregnant. So if that person already knows it or has a family history, that's one indication, and that's called pre-implantation genetic testing for structural rearrangements, or PGT-SR for short. There's also people that are, have a condition themselves, for example, like polycystic kidney disease. So it could be a dominant condition, or both partners are known to be carriers for the same recessive condition, for example, cystic fibrosis or sickle cell anemia. Or another source of PGTM patients is that people do very large carrier screening panels with our clinic. It's kind of standard of care with fertility clinics to screen patients for over 400 recessive conditions, also some X-linked conditions where females can be carriers and can have affected sons. So once people do that test and they possibly have a high risk result, then the counselors contact that patient and talk to them about the results, and then discuss the option of testing embryos for that condition if they want to. So that's another big indication for testing, as well as, family histories for all sorts of genetic conditions.
So when you say testing embryos, how does testing embryos happen? How does this work?
So what happens is, once the eggs are retrieved in the IVF process, then they're fertilized, and then the embryos are grown out to day 5, day 6, at the point where they are what's called a blastocyst. And a blastocyst is an embryo in 2 layers, and the outer layer is what future placenta, and the inner layer becomes the fetus. So our embryologist, they cut out 2 to 7 cells from the outer layer. They freeze those cells, and then they freeze the rest of the embryo separately. And the embryo biopsy is sent out to an outside lab where they do the actual testing of the embryos and send us a report. So that's what I mean by PGT, pre-implantation genetic testing.
Mm-hmm. So thank you. So Evelyn's like, what does helping someone, so what happens in the next time, first time someone realizes that they're just not going to get pregnant spontaneous, or they lose a pregnancy? What is the first steps? Like I think our participant are asking us to bring the level of technicality down a little bit, and because I think not everyone is like is as sophisticated as the two of you. So what happens if someone is not getting pregnant?
Yeah. So we go over, we have an initial consult. We have 60 minutes to go over, at our first visit, go over both partners, if applicable, both partners' history, medical history, all sorts of questions about the GYN system. How have they been pregnant before? What are the menstrual cycles doing? Are they regular? How often do they come? Is the bleeding regular and expected every month? Have they tried checking ovulation at home? There are many urine ovulation kits now that can help with figuring out how to time intercourse if trying at home. So I always go over family goals. How many kids would be ideal? We talk about whether those goals are realistic sort of expectations based on what we're seeing, and how can we help to try to reach those goals. And then I do an ultrasound, a transvaginal ultrasound at that first visit. I look at the uterus, I look at the ovaries. I can assess based on that ultrasound whether there's something in the uterus that might be hindering fertility, like a big fibroid, for instance, in the uterus, which is like a benign, very common benign mass in the uterus, uterine muscle, which tends to run in families, but very common. Or if there's something in the ovaries, is there an ovarian cyst? And how many follicles, which are little cysts that contain a microscopic egg inside. So how many eggs or follicles do we see in the ovaries, which already gives me a sense of the quantity. So going back to quantity and quality, I can assess quantity with an ultrasound and with blood work. We have no markers for quality, so we talk about that a lot. The only objective marker I have for quality is the age of the egg, the person's age of the egg provider. I don't have any blood testing or ultrasound that can tell me whether that 35-year-old has good quality eggs for a 35-year-old or low quality eggs or average. We only know that it's 35-year-old eggs, and I know the number. So we do an ultrasound, and then usually at the end of the visit, we start the workup. So we do some blood work that ranges from the genetic panel that Molly discussed that have nothing to do necessarily with the BRCA, but just a recessive panel of things that people can carry that is important to know if the partner or the sperm provider also carries the same condition. So we run that. We run blood tests that we need for a healthy pregnancy. So what we consider preconception blood work. And then if there is a partner with sperm, we would have a semen, we schedule them for a semen analysis testing and some blood work on the partner as well. And then we regroup to talk about the results. Depending on the situation, I'll also assess the function of the fallopian tubes, because we need at least one open fallopian tube in order for someone to conceive without IVF. Now, importantly, we do not need any fallopian tubes at all for IVF to work, which may be applicable to some folks on here because some may be thinking about or have done what we call bilateral self-injectomy, removing the two tubes as a sort of experimental, currently being studied, but experimental way to try to reduce the risk of ovarian cancer. So if that is done, if the ovaries are still left inside the body, we can still do IVF. We don't need any tubes for IVF to work, but we do need at least one tube for someone to conceive more naturally, spontaneously at home or via something called insemination, IUI. So we do a workup and then we regroup, we talk about the results, and based on the findings, do we have a reason for why there's infertility? And if so, we talk about what the options are based on that. And if we find nothing obvious, then, and that happens a third of the time, so we see a lot of unexplained infertility. I always say it's not unexplained, it's just unexplained to us. We don't have all the tools yet to figure out what's going on. And a big component of that is that egg quality, because we don't have a marker for it. So you can have a 32-year-old who we think is relatively young, but that person might have low egg quality for their age, but we have no way to really screen for that. So a lot of our patients do have unexplained infertility, and then we talk about what the treatment options are based on what we found and what their goals are.
Thank you. That's super helpful. So if I summarize this, and I think we try to prepare our patients a little bit that infertility can be very frustrating because we don't have a lot of good answers. So you can tell someone whether they have any clear structural problems, and then you can tell someone how many eggs they have, right? Or how many oocytes they have. But you really can't tell how well they're gonna do. And I think, and then as Molly pointed out, that in order to assess an embryo, you actually need to harvest the eggs and then fertilize them, and then you let them divide and double and then you can look at the quality, and I think only then you can tell whether someone has any mutations. And so taking all of this in account is are there any blood tests we should that Veronica and Beth and I should do before we send? So someone comes to us and said they try for 12 months. Is there any blood test we should do as a initial workup?
Yes, there are preconception labs that we will want. We can also order them when we see them and draw them at that point. But I think what would be helpful initially, maybe even before they have tried to conceive, especially with the BRCA1, is to have an anti-Mullerian hormone, an AMH, which is a blood test that can be drawn at any time of the menstrual cycle. It doesn't need to be fasting. You could do it when you're on birth control pills. There's really no major restrictions on the blood test. And it's a fairly good, accurate marker of one's ovarian reserve, their egg quantity. So again, no marker for quality. So this is really important because you could have a very low AMH, which again is associated with BRCA1, but that does not necessarily, it doesn't tell us anything about their fertility if they were to try on their own. So plenty of people I've had patients with undetectable AMH levels where it's so low that the lab can't even pick it up and they get pregnant on their own. So it doesn't correlate with fertility, but it does correlate with how many eggs they would get if we did IVF or egg freezing, and with the age of menopause. So that person who has an undetectable AMH or very low AMH already is going to have a much shorter window of opportunity. So if that person doesn't have any immediate plans to try to conceive and or wants to have a fairly large family, right, a multiple number of kids, they're going to need to see someone like myself fairly soon so that we can strategize about how to best make that happen.
And we try to tell our patients that just because we send someone for fertility workup doesn't mean like there's anything wrong. We just don't have a lot of extra time. And I think I really appreciate your comment. If you're over 35 or if you have a limited time span to get pregnant, the fertility workup should probably happen sooner rather than later. So let's talk a little bit about males. And we know that if you are a female and your mother or father had a BRCA mutation, you have a 50-50 chance to have a BRCA mutation as a female. So Molly, is that true for males too? Like, there's a lot of this question, like the breast cancer gene, right? It's like, how does this go to males? It's like, can you speak a little bit about the genetics? I think this is often misunderstood that you can have a breast cancer gene and you're a guy.
Right. Yeah, regardless of the gender, you're going to 50-50 chance that you would pass it on and be a carrier or not. For BRCA1 carriers, for males, have a slightly higher chance for prostate cancer. For BRCA2 carriers, there is a small chance for male breast cancer, as well as other kinds of cancers, regardless of the gender of the person. So, for example, melanoma, a little bit higher chance for that with BRCA. So there's male and female carriers of different mutations that come for PGTM and embryo testing request.
So how
And
can you test in someone's sperm whether they carry a BRCA mutation? How does that work?
no, it would actually be a blood test or saliva that can do genetic testing. But in terms of if they're planning to create embryos, you know, either partner could be a carrier for it, and we would be screening for it.
So if someone has a BRCA mutation, are all their sperms having that BRCA mutation? Is that-
50-50 chance for
No,
each
I think
sperm.
the sperm, every sperm has it, but it's 50-50 chance that the offspring has it, right?
So there's 2 copies of all of our genes. And so if somebody's a carrier, there's just 1 copy that has the mutation, the other copy is normal. So there is a 50-50 chance that their sperm or egg would be carriers or not. And then there would be, you know, just a 50-50 chance that they're passing on that sperm or egg with the mutation or the normal copy. So it's similar to any dominant condition where it's a 50-50 chance to pass it on.
So 50%, so a man with a BRCA mutation has a 50% chance to passing it on. At the same time, a male has a 50% chance of getting it from their mother or father. Is that fair to
Yeah.
say?
So the embryos, we have consent forms where people, you know, can store embryos that are affected, because if there's no other choice, people would definitely consider transferring a male embryo that is BRCA positive, because it's less of a health risk for them than a female.
Mm-hmm. So, Bess or Veronica, what are the most common questions that you hear from our patients in terms of fertility?
Veronica, can I take that one?
Oh, I just want to ask one question before that, if that's okay. What about the sperm quality and age in the BRCA carriers?
There's no association that I'm aware of.
Okay.
That's a great question.
Yeah, thank you for that, Veronica.
So when
Is there like, let's say sperm quality in for BRCA, is there an age where sperm quality is really not ideal anymore?
So yes, so we often talk about like egg quality and the sort of, you know, biological clock for people with ovaries as much more strict, because it is. There's a shorter window of opportunity, but the reality is that even with sperm, with every decade of life, we see a drop in overall fertility. So sperm quality also decreases as the partner's age increases, but it's not as, you can't sort of measure it and quantify it as well as with eggs. Every year above 35, we can see a difference. For sperm and men, it's usually like every decade of life, and especially over the age of 50.
Yeah, in terms of age risk, we would say for female, the only increased risk in terms of genetics are chromosome problems, nothing else, even though it can come from the egg or sperm at any age. While for men, advanced paternal age, or APA, is considered usually over 40, and those are more of a risk for new single dominant mutations. For example, for skeletal disorders and some other associated risks. There's been lots of studies where advanced paternal age are linked to some conditions such as schizophrenia, bipolar, leukemia, and some other conditions, more often in older fathers.
So before we launch into like, what is specific challenging the people with the cancer mutation on fertility. So what we heard is like, don't delay childbearing for too long. If you haven't been able to conceive, seek help. And I think that the number of eggs is relevant, but the quality of eggs is hard to, for oocyte is hard to determine. And both partners can carry a BRCA mutation. So what does someone do who doesn't want to pass on their BRCA mutation to their offsprings? What are the first steps in this, Dr. Mok-Lin?
Yeah, so if they don't want to pass it down, then the ideal next step would be IVF with genetic testing. So IVF is, where we grow these eggs and retrieve them from the body. It's a generally very low risk process. We add the sperm, we make embryos, and then as Molly had said, we biopsy the embryos, freeze them, and then the biopsy gets sent off for genetic testing. We get them back several weeks later, the results, and then we go over how many usable embryos there are. And I say usable because they have to be both chromosomally normal and then preferably BRCA negative, if that was the whole intent of doing this. But there are many of my patients who would elect to, sort of stratify. First choice is chromosomally normal, BRCA negative. Second choice may be chromosomally normal, BRCA positive male. And last choice may be not a choice at all for that particular couple, may be chromosomally normal, BRCA positive female embryo. We would just choose one embryo generally at a time to transfer. So we thaw the chosen embryo, top choice embryo, and we insert that embryo back into the uterus at the right time of the menstrual cycle, and that's called an embryo transfer. And then the rest of the embryos would stay frozen, so that hopefully if that couple wants to have more than one child that is BRCA negative, then they can do so. Several years later, we thaw the next best embryo and transfer. And this can happen even if the woman elects to have risk reducing ovarian surgery. They have their ovaries removed and they are in surgical menopause. They can still carry a pregnancy with our help. We would give back the hormones that are necessary to sustain the pregnancy until the pregnancy actually takes over with the hormone production. So we can still, as long as we already have eggs or embryos frozen, that person can be in surgical menopause and we can still help them build their family.
Thank you, Dr. Mok-Lin. This is actually really helpful because many of our patients who are approaching the late 30s and are really worried about childbearing, but also feel like the risk of ovarian cancer goes way up. And I think BRCA1, BRCA2 is risk for ovarian cancer, so are other cancers where we worry about this. So if I'm hearing you correctly, it's like you don't need to have ovaries to carry a pregnancy?
Correct. You just need a uterus and an IVF doctor to help you with the hormones that you need, because we do need to essentially replace the hormones for most of the first trimester, and then the placenta of the fetus, that placenta takes over the hormone production, and then we can stop the woman can stop taking the extra estrogen and progesterone that we give them.
Mm-hmm. So, and from having been a breast cancer doctor for many, many years, like a lot of our patients develop breast cancer young. It becomes more challenging if you have had breast cancer to carry a pregnancy to term. It's like why we don't think breast cancer and pregnancy, we don't think breast cancer is negatively affected by a pregnancy. What often happens is that we have to interrupt our treatment for breast cancer. And this is like a woman who had hormone positive breast cancer will have 10 years of hormonal therapy. So this is a long time to not be able to get pregnant. And so we have newer data that we can interrupt hormonal therapy after 5 years, but many patients are uncomfortable with this. So it's actually really helpful to know that you need a uterus, you don't need your ovaries. You can delay childbearing for very late as long as you're frozen embryos. Is that fair to say?
Yes, and of course, the other option for those for whom this is an option for them both, sort of personally in terms of whether they feel comfortable with this, as well as financially from a financial implication, is of course the option for gestational carrier or surrogacy, where we take the embryo that was previously tested and frozen, we thaw that embryo, and instead of transferring it to the person who has breast cancer, for instance, and interrupting their therapy, we could transfer it to a surrogate for them to carry.
Thank you. So Molly, a question for you is like someone asked, is like my partner is positive for a BRCA mutation. Should I get tested?
For yes, definitely, because if both partners are carriers for a BRCA, there's certain severe autosomal recessive conditions where there would be a 1 in 4 chance, if both partners are carriers, to have an affected child if both partners are carriers for either BRCA1 or 2. Different conditions would be a concern. But it's not always standard of care to do that. We kind of offer that for the partner. And then we can order that test for them.
Mm-hmm. Now, are there mutations where this has become more? So BRCA1 and BRCA2, when both partners have one gene that's passed on, that can cause some form of early childhood leukemia and a little bit high risk for pregnancy loss. But there's also mutation like ATM, where both partners having an ATM mutation is much worse. Can you speak a little bit to that? What happens when you have both partners with an ATM mutation?
So yeah, that is screened for on this expanded carrier screening that we do for all patients or offer to patients. That's on the panel because it's a recessive condition. If both partners are carriers for ATM, for a condition called ataxia telangiectasia, which is a much higher chance for certain kinds of cancer with that. So that when patients are found to be an ATM carrier, we do offer to have a referral to cancer genetics for their own screening recommendations. But if only one partner is a carrier for ATM, they can do PGTM for embryo testing. And of course, if they're both carriers for ATM, that would be more of the concern for the recessive condition, where of course embryo testing would be recommended as well.
Thank you. So one participant asked, are male embryos also tested for BRCA1 and BRCA2? And I think Evelyn, you talked about this a little bit, and Molly, you did too, right? It's like we are testing male embryos.
All embryos are tested, and one of the tests besides the single gene testing for BRCA on the embryos, they're also doing chromosome testing, which can detect if it's a male or female, so that all embryos are screened.
Mm-hmm. I think if you want to be technically correct, right, you don't actually know whether an embryo is a male before you test. So
right.
So you get the answer whether it's male or BRCA positive at the same time. There's no there's no way of looking at it. It's like
there is an option there are some patients who elect not to know the sex of the embryos, just in general for IVF and genetic testing. I would say 100% of my patients with BRCA who are doing this for BRCA would want to know the sex, because they are, again, sort of triaging or stratifying which embryo they want to transfer first.
So on average, on an average 35-year-old, can we have is there an average how many eggs you harvest? Is there an average that you can tell patients? Do you know, like if you do an egg harvest beforehand, can you tell the patients how many eggs she likely has, or like?
Yes. So I would say on average at 35, it's roughly 15 or so eggs per round, per cycle of IVF. So given that, it's like a race to the blastocyst, the embryo development, and there's survival of the fittest. So not all 15 make it there. On average is about a quarter. So let's say from 15 eggs, 4 embryos make it to the stage where we could we could biopsy it. Then at 35, usually about a third are abnormal. So there may be 2 or 3 normals, chromosomally normals. And then it's a 50-50 on the BRCA. So there may be 1 to 2 usable embryos per round of IVF.
Yeah,
And
we'd say about 50% of embryos are euploid or normal chromosomally at 35, like Dr. Mok-Lin said, and then half of those 50-50 chance that each of those are BRCA negative. So basically each one has that separate chance, like rolling the dice. So because it's a small sample size, the results can look pretty skewed from cycle to cycle. So it might take more than one cycle to try to get some usable embryos, depending on kind of the follicle count and luck and numbers.
And in a 30-year-old, what do the numbers look there?
So usually in a 30-year-old, we get 20 to sometimes 30 eggs. And so now you may have, 6, 7. I can't believe I just said 6, 7. I don't know if anyone knows how.
No, don't do that.
6 or 7 embryos that may be biopsied. But now it's about, let's say most of those are normal at age 30. So now maybe 4 chromosomally normal embryo. No, out of 6 or 7, probably 5 to 6 of them are chromosomally normal. And now 50% drop off from the BRCA. So now you may get 3 usable embryos at age 30.
So I think we don't want to discourage anyone, but I think what I really want participants to hear is like, don't wait until you're 35. This is like not a good proposition. I think it's whenever you have insurance that allows you to do egg freezing, I think that should be done because or like don't delay your childbearing because it is not getting easier.
Sooner the better. Yeah.
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 Can we speak a little bit? So, and how does egg freezing is that covered by insurance? Is like what does this entail? Is it safe? Is egg freezing safe for the female? It's like requires some harvesting associated hormones.
Yeah, I'll address that first, the safety part. There are some risks associated with the procedure. They are very low. One of the biggest risks is just procedure related. It requires anesthesia to do the egg retrieval. It takes us 30 minutes, so it's a very fast procedure, but it is a procedure, so there's always a small risk of bleeding and infection. That's about 1 in 1,000 to 1 in 2,000 risks, so way less than 1%. There's a couple of other like very small sort of short-term risks associated with the actual cycle. There are no long-term risks to the person doing the egg retrieval, like the person who's undergoing the egg freezing, that we know of, including specifically for BRCA carriers. It's not, there's no known increased risk of doing egg freezing or IVF in terms of future risk for breast or ovarian cancer.
And I think that data is now coming out very clearly. There's really no detriment or IVF on the risk of breast cancer. I think we use very high, even if you use high levels of hormones, they're short. They're like there's not been any negative impact. And I think it's now, and as you saw, the FDA removed the black box warning for estrogens in postmenopausal women. I think that's as we learn more about estrogens and hormone is like it becomes very clear that the hormonal intervention are pretty safe. And
also very reassuringly, even in people who already have breast cancer. So we see these folks urgently, usually within 48 hours of receiving the referral. They're diagnosed with breast cancer. We see them immediately. As soon as we get that referral, we talk to them about their options because now we're under a really urgent time constraint of ideally undergoing fertility preservation, freezing eggs or embryos before they may proceed with chemotherapy. We looked at our group under Dr. Rosen, who's done a lot of work in this field specifically, we've looked at this a lot over the years, including specifically at people who underwent fertility preservation after the diagnosis of breast cancer versus met with us. We had a conversation. They decided they didn't want to do this, and they proceeded on with their next steps and their chemotherapy. And we followed them years out to see if there was any difference in anything at all, recurrence risks, their overall prognosis. So even in hormone-sensitive breast cancer that's actively, diagnosed, those people who underwent this short-term hormone elevation that we do for egg freezing, still in the long run, compared to other people who didn't choose to do this, there were no differences. So it's very safe.
So I think the same holds true with one of the participants had a question, like if you have no ovaries and we support folks with hormones early on, that there's not been shown that this is detrimental. So I think it's pretty safe. It's probably more important for someone who's at high risk for ovarian cancer to remove their ovaries than support someone during pregnancy with hormones. I think the ovarian cancer risk increases with age. Beth, what are the main questions our patients have? What is the main questions that you or like Veronica get from patients with regards to fertility?
So the questions really depend on the age of the person. When we have very young patients, like in their early to mid-20s, most of them have not even thought about fertility. This is these days, it's very hard to have children when you're in your 20s. It's very expensive to have kids. It takes a long time to get established. So for those patients, the conversation is to start them thinking about fertility. I explain to them that if they want to have children in the future, they might want to think about talking to the fertility specialist now when they're young and talk about fertility preservation and what would be the best age to do it. And then they can think about it, and later when they have a partner or they're ready to have kids, then they can go back. But at least then they're informed so they can make decisions about what they want to do. If it's somebody who's in their 30s, it's a little bit more complicated. It really depends on what mutation somebody carries. If it's somebody who has BRCA1 and they're in their mid-30s, they're actually approaching the age at which breast cancer frequently gets diagnosed. And so those patients want to know, what should I do? Should I do a mastectomy before I have pregnancy, or what order should I do these things in? And we talk about the pros and cons of eliminating their breast cancer risk before they go into childbearing versus doing screening during pregnancy or trying to do screening. It's a little complicated. If it's somebody in their 40s, I just send them to REI right away if they're still talking about kids.
Are there patients where you would not pursue anything further? Do you have like a criteria where you would not recommend further pregnancy workup or like further fertility workup?
I can take that one. I mean, because the probability of success is so low with both quantity and quality over the age of, really 42, 43, but most IVF clinics in the country cut off, including ours, stop doing IVF with that person's own eggs at age 45. But even prior to 45, sometimes it just doesn't make sense. Even if they haven't reached the 45-year mark, we would talk about how many follicles we see. If we're getting one egg per month, the chances of that being usable is going to be extraordinarily low. So there are also, something that we haven't touched upon is some people do elect to then consider alternative ways to build their family, including using, for instance, donor eggs. So someone else's eggs They are usually in their 20s, healthy, no major medical issues, and do not have BRCA, so we would not have to test for the BRCA if the variant was originally in the female partner. So that is something that some people like to do. Donor egg, partner sperm, if applicable, make an embryo. We transfer the embryo to the female partner's uterus. So again, that person can still have had their ovaries removed or in their bodies. And either way, as long as the uterus is there, they can still carry a pregnancy, but use donor eggs instead of their own eggs.
And then do you screen the donor eggs?
I mean,
BRCA
we don't
mutations?
we don't generally recommend doing genetic testing for chromosomal abnormalities with the donor because they're so young. So the vast majority of them are normal. It's still an option if some people want it for specific reasons, but medically it's not necessary.
They can screen the embryos for chromosome problems, which is pre-implantation genetic testing for aneuploidy, but the PGTM would not be indicated unless it's an identified mutation in that person. Yeah.
So let's say someone is 27 and they decide they want to like freeze their eggs. Are their eggs genetically tested before they're frozen, or they only tested when they are embryos? And
Right. So we can't do testing on the egg because it's a single cell and it's missing the other half of the genetic material at this time. I mean, I wouldn't count this out for 5 to 10 years from now with AI and other things that could potentially just use the image of the egg to maybe non-invasively figure this out. But right now, we can't biopsy the egg. We can't test the egg. So often my sort of strategy with folks is if they are freezing eggs, that we have to essentially freeze twice the number for the number of kids that they would want compared to someone who doesn't carry BRCA. So if a 30-year-old comes in and says they want 2 kids, and normally I would say you need to freeze 20 to 30 eggs to have a fairly good chance of having 2 kids, in someone with BRCA, we would have to double that number.
so what is the success rate of a live birth with like egg freezing versus embryo freezing? Is there a big difference?
Embryos do freeze and thaw better than eggs, so they are a more they're less fragile in the freezing and thawing process, but we're so good at it at this point. Our embryologist, our IVF lab is so good at this that the difference is 5 to 15%, depending on the age of the egg. But embryos still do better. They freeze and thaw better. But the main advantage right now is that embryos, we can do all the testing that we talked about. So we can find out right now which embryos are usable. Whereas with eggs, we're hoping for the best, and we're saying, if it goes according to average, 50% of these eggs will have it, but we don't know that it will go according to average.
And the implantation rate, if it is a chromosomally normal embryo, is about 60%. So that's why it's recommended to have at least 2 embryos per child that people want, because of that chance of that normal embryo resulting in a pregnancy.
And is it pretty standard that we only transfer 1 embryo? No longer have like multiple embryos?
If it's a euploid embryo, it's a single embryo transfer. Yep.
So why is this when we started our career, we would transfer 2 or 3 embryos, and now we do 1? What happened? What changed?
I mean, that was really primarily the advancement of pre-implantation genetic testing, because we didn't have that. So in the past, we still do this. We still grade them based on what the embryos look like, their morphology under the microscope. The nicer the embryo, the higher the grade of the embryo, the more likely it will work. But we were doing it just by visual sort of inspection and grading. And we knew that a 42-year-old would have a low chance of each of those embryos being normal, but there wasn't a great way to know that ahead of time back then. And so we would sort of play our statistical odds and transfer 4 at 42, thinking that only one of them is going to likely be normal. But that particular person, that goes back to our egg quality, that particular person may actually have excellent egg quality for 42 and have 2 out of the 4 or 5 be fine and have twins. Additionally, even when we transfer one, we have like a 2 to 5% chance that that one can split. So even when we transfer one, you can have identical twins from that one embryo.
Okay, great. Veronica, any questions that you come up in your clinic that
Yeah, I think people are really concerned about the cost of these procedures because it figures into their fertility planning. So if you could shed any light on that, that would be helpful.
Yeah. So thankfully, starting next year, a lot of Californians will have much better IVF coverage for infertility because there's an infertility bill that the governor signed into effect that starts January 1st. There's a couple of exclusions, but most people will have access, a lot more people will have access to IVF. It includes up to 3 IVF cycles and unlimited frozen embryo transfers. We're kind of on pins and needles waiting for this to roll around. There's a lot of people waiting for the first week of January for us to submit insurance authorization to sort of test this out and have it see what happens with the insurance policy. But that is the new law, which is great. What it doesn't cover is fertility preservation. So there is a fertility preservation bill in California that went into effect a couple of years ago that says medically indicated fertility preservation. So if someone has cancer and is about to have chemotherapy that will render them infertile or immediately in menopause, then egg freezing or sperm freezing for cancer in men, fertility preservation that is medically necessary should be covered by insurance. But if we want to freeze eggs because we want to test for BRCA later, they're not ready to conceive now, but they don't have a cancer diagnosis, that would still be considered elective fertility preservation, unfortunately, so that would not be covered by insurance.
but I think I would still caution everyone to really look at their insurance coverage and their blueprint and possibly even call the insurance company to find out what's covered. Some insurance programs are very generous, others are not, and I think there's often a good chance that an open enrollment, this is a time where you go with a plan that may be more helpful than others. I think insurance companies are not all the same, and I think some are more generous.
The other thing is, just to say really quickly, is that I don't know where folks are joining in from, but in the Bay Area, we're in this unique place where a lot of the tech companies also offer separate carve-out fertility coverage. So I have had people change jobs just for that reason, knowing that they're going to need to do multiple rounds of egg freezing. Their regular insurance is not going to cover it because it's technically quote unquote elective. Although it's not really elective. I don't really like the term in that case here because we're saying you have a shorter reproductive window and you need to actively plan for this. But because there's no urgency or there's no event that will cause them necessarily to be infertile that we know of right now, it is considered elective. So I have had patients actually switch jobs because there are certain companies that are very generous with specifically fertility benefits. So it's outside of like Aetna or Blue Cross Blue Shield and a separate fertility insurance carrier.
Yeah, many of these tech firms offer that, and people stay at jobs until they're finished with their cycles, even if they want to leave.
I also had a patient of mine who had a surrogate entirely paid for by a company policy, and she specifically sought a job with them for that reason. So I think, look, I think it's important for all of our patients and family members to know that fertility is something that has to be a little bit front and center of a discussion on planning, because as I said, like what often happens with our BRCA carriers, like you're like 30, you think it's all fine, you haven't gotten around harvesting your eggs, but you get that MRI that is an abnormal MRI, and we find that breast cancer, and then everything becomes an incredible race to get eggs harvested before we start treatment. So I think there's an abnormal lab that prompts us to take the ovaries sooner. So I think please do not delay this. And I think Dr. Mok-Lin, you don't get to say this to people, but I think the message has to be loud and clear. Don't start this at 37. Right?
Yeah, I always say that as OBGYNs, nationally, which is important, we do a fairly good job as a field of discussing and counseling about contraception. Super important, how not to get pregnant. But what we don't do as good of a job of is at what age do we flip that conversation and say, what are your family building plans? Because if you want to have 3, 4, 5 kids, you know, it's not realistic to start in your late 30s. We have to really start planning for that sooner.
I looked at a statistic calculation the other day, and I sent this to my children, and I can assure you I did not make a lot of friends. If you want to have 3 kids naturally, you need to start at 23. And I did not make friends with my kids, as you can imagine, but and that's probably a little bit tongue in cheek, but it's you know, I think there's a lot of myth in the public domain about all these women who get pregnant at 45 and how easy this is. It's not easy. I think it's fair to say it's really not easy, because even if you don't have a cancer risk where you have competing risk for getting cancers early, is like even if you're like a person with no cancer risk, the risk of, as you say, Molly, like the risk of having abnormalities in the chromosomes in your eggs becomes very significantly increased after 35, right? It's like
Are there any modifiable risks? You know, are there things that patients can do to increase their fertility?
Yeah, that's a great question. Let me take one step back about the celebrities, because I think that's like so prevalent is, well, you know, Janet Jackson got pregnant at 50 or whoever. The Kardashians, you know, most of them had assistants. They just don't publicize it. And there's a large number of celebrities whom I cannot name for HIPAA reasons, of course, who use donor egg. But they're not going to be public about that because it's their own personal, private family matter. They don't need to be public about it, but also because we encourage people to disclose it to their child as soon as possible, but they're waiting to disclose it to their child. So they're not going to, when they get pregnant with a donor egg, they're not going to announce it publicly because they're waiting for the right time to tell their child, you know, their, you know, kind of family origin story. But you would be surprised by how many people in the public eye or not that did not conceive with their own eggs. Or if they did conceive with their own eggs, they were probably also, and they're much older, were probably frozen. And that's going to be more and more common because now egg and embryo freezing is increasingly more common. In terms of modifiable components, that's a great question. We do know, for instance, heavy smokers, tobacco smokers, go into menopause earlier. So it does seem like heavy tobacco smoking accelerates your loss of your eggs. So I would encourage people to not smoke. Marijuana has been studied pretty significantly in both eggs and sperm. It's very, it's not super straightforward for a number of reasons, but I would encourage folks to limit that as much as possible. And any other drug use. Alcohol, significant alcohol, and you know, what is significant, but over 7 drinks a week or more is associated with lower fertility as well. So, and then also like high BMI and low BMI is also associated with lower fertility compared to those who are normal BMIs. So, I think in general, I recommend that people try to be the best and the healthiest versions of themselves to the extent that is possible. I wouldn't, it's hard because I think sometimes it's already stressful having BRCA. It's stressful having infertility. It's stressful thinking about your biological clock. I don't think it's necessary to stress about the stress. That's a big one. Like, how do I need to decrease my stress? We don't have any data that suggests that stress increases your infertility. It can cause more irregular menstrual cycles temporarily, but our psychologists have actually looked at that a number of years ago of whether undergoing IVF people who have the highest stress versus the lowest amount of stress didn't have any difference in their pregnancy rate. So that's reassuring. So I say, do your best to be as healthy as possible. But those are the big things: is alcohol, smoking, drugs, and just a healthy weight as much as possible.
Thank you. Let's go through a couple of the questions, like how many frozen eggs are needed for IVF to have one baby? My eggs were frozen at age 29. Thank you. That's a difficult question.
At 29, it's roughly 8 to 10% live birth rate per egg. So let's say 10% live birth rate per egg. So if you have 10 eggs, there's a very, very good chance. We generally never say 100% for anything, but there's a very high chance that you will have one live birth, but that's not accounting for the BRCA if that's applicable.
Okay, and then the question is like, when I had egg retrieval at the age of 29, 20 eggs were retrieved and only 8 were mature and of great quality. That's what the nurse told me. Why didn't they freeze all 20?
So only mature eggs can be fertilized. So depending on the clinic, most clinics only freeze the mature eggs. Sometimes what we'll do, we do this routinely for our cancer patients for whom we think this might be their only chance to get eggs. We might not be able to get any more after chemotherapy. We do something called in vitro maturation, where the lab, our embryologists try to sort of nudge the embryo to see if we can get them to be mature overnight for those that are immature. And if they make it the next day, we will freeze those. But those have a lower probability of success. So we don't generally routinely do that. We just do it in the circumstances where that may be our only chance. That may be that patient's only chance to get eggs.
And following up on Veronica's question is like, do you get charged per egg? How does freezing, what is the cost for egg freezing? Like, what are
So
the
if
charges?
it's not covered by insurance, don't quote me on this, but out of pocket is probably around $12,000 to do one round, whether you get 1 or 20. And then every year it's about $800 to keep them stored per year. So every year, so if you froze it this month, next December of next year, you would get an invoice for the subsequent year. So it's about $800 or so a year to keep them stored, whether you have 1 or 20. And eggs and embryos, as far as we know, can be stored. There's no absolute maximum duration, but we have the most data under 10 years because not many people will freeze them for more than 10 years and come back to use them. But there have been embryos that have resulted in a live birth, healthy baby, after being frozen for 30 years.
Super helpful. I think that's one of the questions.
Okay.
Molly, if I'm BRCA1 and BRCA2 positive, what percentage of eggs have at least one mutation?
So it would be a 50% chance for each mutation to be at each one. So about a 25% chance to have an embryo that is not carrying one of those variants.
So 75% of them have either one of them.
Yeah.
Okay. Thank you. And then So for those who are BRCA1 and opt to remove ovaries and then use frozen eggs, is it more effective to use a surrogate or carrying it themselves?
It's the probability of success is the same whether they have their ovaries or not, assuming that the uterus is fine. So, I mean, it's a little bit of a tough question because in general, surrogates, in order to be a surrogate, surrogates have to have had a proven healthy full-term live birth. So of course, the person who's had a healthy full-term live birth is generally more likely to have another full-term healthy live birth compared to someone who's never been pregnant. So generally, surrogates have a higher probability of success compared to someone who's never been pregnant. But someone who had their ovaries removed who's never been pregnant versus someone who had their ovaries who's never been pregnant, with our help, the chances of that embryo implanting is the same.
So if you had someone who had their eggs frozen at 28, right? But now they are 34 and and AMH is looking good and they want to do spontaneous pregnancy, do you recommend that they do a spontaneous pregnancy or recommend that they use their frozen eggs?
Great question. That one we get a lot as well. I am very much, if you do not want to screen for BRCA or any other mutations that we are worried about, I do recommend it, and you have regular cycles, everything else looks normal. I would recommend that people try on their own first for a couple of reasons. One, because we may want to save those eggs for baby number 2 if they want more than one child, because as that 34-year-old gets older, they are more likely to need these eggs. So I'd rather you try on your own, conceive as naturally as possible, and save these eggs as a backup for later when you're going to need them more. The other reason is because we do have a lot of data that spontaneous conceptions have lower risks in their pregnancy. So IVF pregnancies are generally considered higher risk compared to pregnancies that were conceived naturally. Now, whether that's IVF in and of itself, the process of IVF, which it could be, or if it's because of the patient population that needed IVF, right? The majority of people doing IVF have infertility, and whether that infertility also increases their risk of pregnancy complications certainly could be true. We don't know that. So, but we do know consistently that IVF pregnancies have higher risks during the pregnancy. IVF babies also have a 1 to 2% higher birth defect rate compared to spontaneously conceived babies. And again, we don't know if that's IVF in and of itself or because of the infertility nature of the majority of people doing IVF. So,
Can you repeat the last part? That was actually very, very complicated, if you don't
yeah.
mind.
So IVF babies so spontaneously conceived babies, naturally conceived babies have a 3 to 5% birth defect rate. All birth defects combined, like when the pediatrician examines the newborn and anything that they can note. It could be really insignificant or it could be something big like cardiac.
And it may be able to be seen prenatally or not.
Right. So 3 to 5% of naturally conceived babies have a birth defect. 4 to 7% of IVF babies have a birth defect.
So it's higher. Okay.
It's higher.
It's really good to
Yeah.
know. So you recommend anyone who has a chance and an opportunity to conceive spontaneously to do this, even if they have frozen eggs?
Correct, as long as they're not trying to screen for the BRCA, because of course, conceiving on their own will now put them at risk for 50-50 chance of passing it down. The other thing is, of course, if they have really irregular cycles, if they are 43 and you have 30-year-old eggs, then the probability of success at 43 is going to be so low that it would make sense to just use those frozen eggs.
There is an option to do prenatal diagnostic testing for BRCA too, kind of a case-by-case basis as well, if you did not screen the embryos.
We're coming up on times like Beth, Veronica, do you feel like you know everything there is to know about fertility and recommendations? Like this is what you get when you talk to two fabulous experts. You think like now you know it all, and then an hour later think, What about that situation?
I know, I feel like I want to lock them in a room and interrogate them for hours. Wonderful information. Thank you.
I would
So-
say I know just enough and I know where to refer people.
So any closing comments, Molly, anything that you really think people should know, we want to get across?
They're welcome to contact the clinic and ask us questions. You can call the main number and they transfer to one of the counselors. If they, are interested, and of course they can get a referral to have a consult with us as well. Happy to speak to you.
Dr. Mok-Lin, anything that you think you want to get across?
I think I do want to emphasize that the low AMH, because that often stresses a lot of people out. The low AMH does not equal infertility. It does mean that we really have to think about it sooner and make a plan. And it may mean more than one cycle of IVF to get the number that you need, but it doesn't mean it's not associated at all with quality. The other thing I want to point out that's not always obvious for folks is that if there is a diagnosis of cancer, while the main concern with chemotherapy is that it will drop and destroy the remaining bank account of eggs so that the quantity goes down all the way down. So you could be in very early menopause because of that. But if there are eggs remaining, which is more likely when people are diagnosed at a younger age, if there are eggs remaining after chemotherapy, as long as it's been at least 6 months after the last chemotherapy exposure, we can still get eggs later, or they can conceive on their own when they're cleared by Dr. Munster. And there's no difference in egg quality, because I think a lot of people are worried that the chemotherapy would cause birth defects or something else with their pregnancy, but we have plenty of data on cancer survivors who ultimately become pregnant, and there's no difference in terms of their pregnancy health or their baby's health, as long as they've been out of the kind of very recent exposure time period.
So I think speaking of this is actually a good segue to end. So I think we have done studies, myself and others have looked at the fertility rate after chemotherapy. And just because you lose your period doesn't matter, you're not fertile. So as soon as your period is back, your fertility is a good chance to be back. Of course, this is again like at 35, this is different. If someone has chemo at 29, there's a very high chance to stay fertile. That being so is though we make every effort when someone gets diagnosed young with breast cancer, we send them to fertility. An egg harvest before chemo. We can always wait with the chemo. This is not leukemia. We can always wait 4 weeks, 6 weeks. We can induce egg maturation safely. And so I think anyone who's been in this situation, who is diagnosed with breast cancer, don't panic, get your eggs harvested, because we do it just as you say, Dr. Mok-Lin, is like, maybe they get pregnant with the spontaneous with one child, but maybe not with the second and third. And I think it's really, and really you taking your point is like, yeah, you may get your spontaneous pregnancy, but for the second and third, you may need assistance. And if you don't need a uterus, if you don't need the ovaries and don't need fallopian tubes, you just need a uterus, you can actually, once you have egg harvested, you can actually delay your pregnancy. That's the one time you can delay your childbearing if you have everything frozen. So, Beth, any closing comments from your side?
I think this was a great session, and I really appreciate our friends from the reproductive services being willing to come and talk to our patients. When in our clinic visits, these subjects come up all the time, and as you all know, we refer tons of people to you. But being able to have this many people hear you talk about it has been, I think, great. Thank you.
And genetics are complicated, as you heard from Molly. There's a lot to know, and a geneticist can walk you through very complicated concepts. And I think we have an amazing team, and thank you so much for the both of you just being there for us. And I know you're always available for us, and questions that we have and questions that our patients have. It's like I think this is an incredible service and a great webinar. So thank you, everybody, and Lou, thank you for organizing this, and like have a wonderful night. Thank you.
Thank you.
Thank you.
Happy holidays, everybody.
Take care.
Yeah.